Good evening, everybody. Hey, this is Craig Merrill. I'm on the sales team with Transcend Biologics.
Yeah, thanks so much. Craig, give me a thumbs up if you can hear me. Make sure our technical issues are dealt with. You can hear me okay?
Yep.
Fabulous. So please feel free to type in the chat at all. If any of you have been here before, welcome back. If you're brand new to this, it's all going to be brand new material. So I'm a sports med doc, and I'm here to help you learn a little bit more about how to use ultrasound and PRP to help your patients. You know, over the past 5 years, we've taught 60 courses now. I'm going to Portland to teach our 61st course, and I've met some great docs all over the place. And almost none of these people you just saw in those pictures use PRP in their practice. And I started scratching my head and I say, why is almost no one using it? And I came up with a couple of barriers. A couple of barriers where it's simply, it's like a confusing medicine. Like, how much do you use? How do you make it? You know, is my nurse going to draw the blood? You know, there's so many barriers. So I said, look, I'll just try to eliminate as many of the barriers as possible. And I came up with this online PRP course. And this PRP course is essentially breaks it down the product, the patient, and then finally the procedure. So there's a free version of this Learn PRP course that you can find on our website, sportsmedus.com/free. But let's get into it. So in this free PRP course, there's all these documents to help you, assess your patient, counsel the patient on what they should be doing before their treatment and after the treatment, along with a lot of patient-reported outcome measures. And I think these are super important because when you do a treatment for somebody and they're going to come back and you say, how are you feeling? Did it work? If the patient got a 30 or 40% improvement, they will say, doc, it didn't work, right? And so you've got to be able to capture those 30 to 40% improvements, and that's where the patient-reported outcome measures come in. Also in this PRP course, there's 25 demonstration videos of different injections that I've done in my clinic with patients. I've edited the videos so you can see exactly what you should be seeing on the screen with your patients through these videos. So I'm going to jump forward to slide 155 in this PRP course, and we're going to jump straight to the Transcend product. So one of the beautiful things about the Transcend product is it is super duper easy to make a really high quality PRP with this gel tube. Now the beauty of this is it's a 22 mil draw. So none of this. So there are some products on the market that pull 60 or 90 or 180 mils of blood. And let's say you just want to do a tennis elbow. You really only need 1 or 2 mils of PRP tops. Well, this 22 milliliter draw is perfect for that. So let's say you want to do 2 tennis elbows or a rotator cuff and 2 tennis elbows. Well, Transcend Biologics sells a product where you can buy a 22 milliliter tube and an additional 22 milliliter tube sort of packaged together. So essentially, this one will give you enough PRP to be able to do 2 tennis elbows, and then this one will give you enough to be able to do their rotator cuff. It's a super duper fast spin. You know, this is set at 10 minutes, and I think it's a lot quicker than 10 minutes, isn't it, Craig? Feel free to punch it in the chat. I feel like it's a little faster than 10 minutes, but even if it's 10 minutes, that's still pretty quick compared to some of the processing on the market. I met Michael O'Brien. He's a CEO of Transcend. I met him last year in Pensacola, Florida, and he did a video telling me all the advantages of it. And I think there's some really good advantages of the Tropicell's product compared to some of the other gel tubes on the market. But I'll leave that for Craig to reach out to you and your staff after the webinar. Let's get straight into the clinical aspects. So what do we, the biggest thing, you know, I had a guy in today and I did a PRP for his knee and for his shoulder. And the issue was the following. He said, look, I've got a rotator cuff tear and I'm interested in helping to heal up that rotator cuff. How well will PRP work? And I say, well, you know, there are some studies that can help guide us on this. Rotator cuff study was done in Ankara in Turkey. And what they did was they took 40 people over the course of 1 year, and they did an exercise program for everybody. And in half the group, they did saline injection, and half the group, they did PRP. And they found that the PRP group was equal to saline at 1 year. So what do we take away from this? Do we take away from this that you should be doing saline injections, or do we take away that you should be doing PRP injections? Well, I think the most important thing is to say, look, everybody did an exercise program. I really think that the exercise program is probably the most important part of any treatment for PRP or for cortisone or for surgery or anything. So I'm honest with my patients and say, look, I could probably get a reasonable response for you if we just do an exercise program. Usually my patients will come in and say, hey, I've done an exercise program for the past 6 months and I'm not getting anywhere. I'll say, all right, would you like me to inject saline for your rotator cuff, or would you like me to inject the PRP, which actually has a really good chance of helping to heal up that injured rotator cuff? And of course, everybody says, well, I want the actual treatment. I don't want saline. So how about some other studies? You know, this was a study done in Philadelphia in 2013 where they took 19 patients over a year. Now, this one in Turkey, what they did was they injected above the tendon. Well, PRP shouldn't, for the best result, shouldn't be injected next to a tendon. For the best result, it should be injected into a tendon, whether it's an Achilles or a rotator cuff. So this 2013 paper in Philly, what they did is they took 19 patients, they injected into and around the tendon. They scanned them with an MRI machine before, and they scanned them afterwards. And what they found was not only did it improve pain and function and patient satisfaction, but it also improved their MRI findings. So you can point to this and say, look, the PRP, I really do think will help make your MRI look better, and it'll help your pain and help your it'll help your function. Now, you've got to be honest with people, in my opinion. People will say, will this heal my rotator cuff tear? And I say, well, let's think about your rotator cuff tear. Your rotator cuff tear is 3 millimeters by 7 millimeters. I think this has a really good chance of helping strengthen all the tissue around the rotator cuff tear. Plus, it has a small chance of helping to heal up some of that 3 by 7 millimeter tear. Maybe we scan it again in a year and it's gone from 3 by 7 millimeters down to 1 millimeter by 4 millimeters or something like that. So I'm honest with my patients. I say, look, this is not like a magic potion to heal up a tear. So how about a tear that is something like 90% or 100% of the rotator cuff tendon? And you got to be honest with people and say, look, this is not surgery. You can't just put in some blood and have it magically regrow a tendon that has ripped off the bone and retracted by, a centimeter or 2. So that's the most important thing, I think, with PRP is you've got to select patients that are willing to do it, willing to do the PRP, willing to do the exercise, and who are understanding that this is not a magic treatment that's going to get rid of the patient. So top tip, grab your pen, grab your pencil, write this down. The best patients that I have found are the following: police officers, firefighters, and military personnel, and bodybuilders. Why? What do they have in common? They realize, so police officers and firefighters, they're exercising, as part of their job. Most of the cops and most of the firefighters I talk to say they've got some time carved out into their day to exercise. So they exercise a lot. Bodybuilders exercise a lot. The other thing is they also hang around a lot of people who also have little injuries. And so they get to chat with people and say, well, what did you do? What did you do? And so by the time a firefighter or a cop or a bodybuilder comes in to see you, they probably have a really elevated opinion of what PRP can probably do for them. And hey, I'll take that advantage. If the patient thinks the treatment's going to be amazing before you even give it to them, I'll take that and run with it. But you still got to be honest with them. And so I think some people like to see the studies. Other people say, look, I don't care about the studies. What would you do if you were me? And for the guy today, I said, look, we can get you to a surgeon. He said, I absolutely don't want surgery. I said, look, we can do cortisone. He said, I don't want drugs in my system. The last time I had cortisone, I felt funny. Look, I've got some substance abuse issues in my past. I'm just not keen on chemicals. I would way rather do something natural. So when I've got somebody who is reasonable, who wants something natural, non-chemical, who says, I don't want surgery, I've already got a physiotherapist, for me, it's game on, like tick, 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 tick. And we did the PRP same day. So I think that's super duper important. So how do we know where to put the PRP into the rotator cuff. Well, the first thing is we want to figure out where the pain is coming from. So for example, this is a PRP I did for a gentleman. Now, what I do with PRP is for rotator cuff is I don't put in any anesthetic right away. So there's 3 reasons I don't put in anesthetic right away. Number 1 is there's some evidence that anesthetics such as lidocaine or bupivacaine can reduce the function of stem cells. I haven't actually seen papers that I can think of to say that they reduce the function of platelets. I'm sure they're out there, but I can't think of anything off the top of my head at this time of the evening. So that's the first thing, is it'll probably reduce the function of platelets, because I know it reduces the function of stem cells, even though if I don't have a platelet study. The second thing is anesthetic is mostly water. So when I take a bottle of 1% lidocaine, and here, I'm just going to hit play on this video here. So here we are at the superficial most fiber. I'll see if I can turn down the volume so I can talk over top of it. So the second thing is anesthetic is mostly water. If I take a bottle of 1% lidocaine, it's 1% lidocaine, and what's the rest? Well, the rest is 99% sterile water. So if I've just taken this person's blood and concentrated it to 2 or 3 or 4 times or 6 times or 8 times or whatever, if I pre-treat the area with water, I'm immediately diluting this expensive product that we've just spent a lot of time concentrating. The third reason I don't put in anesthetic right away is I want to put the PRP in the body part that is painful. So when somebody comes in with a rotator cuff tear, so imagine they have a, this is their whole rotator cuff, and this part of it's torn. Well, there's where the tear is simply joint fluid. You put your needle right here and the patient says, no, I don't feel that at all, doctor. If you touch the edge of it and they say, oh yeah, that's a sore spot. Well, that's the area that is not torn that's painful. So I put some PRP here. I then move my needle over here, and if I touch this part of the tendon that is still intact, so let's say it's adjacent to the tear. Let's say they have a supraspinatus tear that's like that, and I'm touching the infraspinatus. A lot of times it's the stuff that is not torn where they actually have pain. So if I had pre-anesthetized the area, I completely lose my ability to find out where their pain's coming from, to put the PRP in the painful spot. So what a lot of docs, so when I teach docs in my courses and they start doing PRP, a lot of times they say, oh, I just put my needle right in the middle of the tear. So I put my needle right here and just flood the area. Well, that's bouncing off the area that's torn, but it's not filling up the torn area. So I really think you shouldn't pre-anesthetize people. Number 1, because the lidocaine can probably reduce the effectiveness of the treatment. It will definitely water down the concentrated product, and it takes away your ability to find out where the painful tissue is. Now, there are some situations where I will pre-anesthetize people, and that one situation is the following. If I think the patient will not tolerate the treatment well, so let's say they're super duper squeamish. Well, number 1, I don't like treating people who are super duper squeamish with PRP anyway. So if I don't think they're not going to tolerate the treatment well, I've treated some teenagers, some really gnarly patellar tendons, and so I'll hit play on this video again just for something to just be able to watch something while I'm chatting here. I've treated some pretty gnarly patellar tendons in some teenagers. Well, for a teenager, I don't want to psychologically scar them, right? Because they've got a long history, they've got a big, long future ahead of them. And I want to be able to get through the treatment with PRP without psychologically traumatizing them, so they never come back for more PRP in their life. So essentially, that's the reason why that is the one scenario where I will pre-anesthetize people. Okay, so what do you put into a supraspinatus tendon? Well, so in our paid PRP course, we've got information on cortisone and hyaluronic acid and prolotherapy and PRP. Here today, I just want to show you some examples of how I do decision making. So the timing for a supraspinatus tendon tear or infraspinatus or subscap tear, I won't usually do an injection within the first 6 weeks of the injury. Usually by the time people have seen me, they've injured it, they've had a scan, they've been to therapy, and they're not getting any better. So I'll usually see people well after 6 weeks anyway. But if somebody had fallen and done a small rotator cuff tear within the first 6 weeks, I don't think I'd treat them right away. I'd say, look, I think you'll do fine. Let's get the shoulder moving. And I don't think PRP is going to be needed for you. I think, excuse me, I think an optimal candidate is somebody with no tears. So simply tendinosis would be an optimal candidate. And a suboptimal candidate would be someone with a visual analog score pain scale greater than 7 out of 10 with activities of daily living. So here we go. So there's the timing, the optimal candidate, the suboptimal candidate I was just chatting about. If somebody's got a full thickness tear with retraction, I'm filling out the surgical referral form as I'm chatting with them about PRP. Why? Because if somebody's got a full tear with retraction, I want to give them the opportunity to chat with a surgeon, because what I hate is the following. I hate it when somebody comes to see me, I do my best to explain things, we do a treatment, and then further on down the road, somebody throws me under the bus. So let's say I do a PRP once or twice in somebody with a full tear with retraction, and they don't get very good response. They eventually see the surgeon, and the surgeon says, I do not know what Dr. Johnson was thinking. He never should have done that. He never should have taken your money. I don't know why he did that. It doesn't make any sense. So, because I've had that happen to me where my patient and I agree, yeah, let's do the PRP. And if it doesn't work, we'll do surgery. And then they go to the surgeon throws me under the bus. I'm like, hey, there's no reason for that. We both thought it was a reasonable thing to do. And the surgery is always going to be the last thing we really want to do. So my personal way of doing this is if they got a full thickness tear with retraction, I'm filling out the surgical referral immediately and say, hey, totally up to you. Would you rather wait and see the surgeon and come back and see me afterwards if you guys agree surgery is not right for you? Or would you like to do the PRP now and just see how it goes? And I leave that in the patient's lap. And that's my personal preference from having been burned before. I try to learn from my mistakes or my embarrassing moments rather than ignoring them and making the same mistakes again. So if you were to do anesthetic, and I'll spend a little bit of time on this algorithm here because there's a lot of things from this algorithm that will carry over into the other body parts. If you are going to use anesthetic, write this down, screenshot this, take your phone out, take a picture. Here's what you would do. You would either use ropivacaine 0.2%, and you can get these shipped in your clinic in a multi-use vial with preservative in it. So you can crack open a bottle. It's like 50 or 75 bucks for a vial. And you can use a really small amount of ropivacaine. It's been proven not to reduce stem cell function. Once again, I can't immediately off the top of my head think about any platelet function studies. But I know that it's fine to use. And when I talk with other presenters who teach PRP, when I talk with other guys who do stem cells, they say, yep, I'm okay with ropivacaine. The other way of doing it, if you don't want to keep ropivacaine in your office, because I can't get ropivacaine very easily where I am. So what I'll do is I'll take a syringe of normal saline. So for example, I've got a 10 mil syringe of normal saline if I'm going to do a lateral hip or something. And the 10 mil syringe of normal saline, sterile normal saline for injection, I'll push out 1 milliliter of that. I'll then go to my lidocaine vial and I'll draw up 1 milliliter of lidocaine 1%. So what have I done? I've taken my lidocaine 1% and watered it down to lidocaine 0.1%. So what I do then is I will then use really small amounts into the skin, into the needle track, and then really small amounts to the target. So that's what I will do if I'm going to use any anesthetic at all. But once again, my preferred way of doing it is no anesthetic if you think the patient can tolerate it. So what PRP am I going to put in? Well, leukocyte poor, leukocyte rich. I like to think about these as red PRP or yellow PRP. Now, if you've not made PRP before, super duper simple way of thinking about it is the plasma sits on top. If you use the tropicell system, all the red cells get trapped under the gel barrier, okay? And and everything up top is yellow, meaning with the Tropicells system, you don't get any sort of contamination of red cells into your plasma. If you're using a different system, and the way you produce it might actually get a bit of red cells into your plasma. Now, if you're separating PRP just in a tube, so let's say you just take a regular test tube from the lab and you spin your blood, what happens is you have yellow on top, red on bottom, and what's called the buffy coat in the middle. And there's the highest concentration of platelets right in the center, the bottom of the yellow, the buffy coat, and the top of the red. So a great way to get a ton of platelets is to grab some of the very, very top of the red. But what happens is you wind up contaminating your plasma with some red cells. And what do we know about red cells? Let's say you have a hemarthrosis in your joint. It's really provocative to the joint. It's really inflammatory, and it can actually break down cartilage. So there's a huge shift in the PRP community to say we really just want a yellow PRP. We really don't want any red cells if we can get away with it. Now, again, there are some situations that say, there are some papers out there saying the leukocyte rich, AKA the red sort of contaminated PRP, does great in some situations for tendons or muscle tears. But many of the docs that do PRP for a living are moving more towards the yellow PRP with no red cell contamination. So what are we going to do afterwards? Well, sorry, for supraspinatus, I always want to make sure I've got a 5 milliliter syringe. Now, that sounds like a ton of PRP for a supraspinatus tendon. Imagine imagine a common extensor tendon. It's already full of stuff. Like, you can't put much PRP into it. However, with rotator cuffs, I want to make sure I've got 5 mils of product. Why? The reason is because rotator cuff tears that have previously been scanned somewhere else in the past might have evolved. And what that means is when you put your needle into the tear, it might be obvious that the first mil or two you push flows away somewhere into the joint or into the bursa, and all of a sudden you didn't even get a chance to fill up this part of the tissue well, and then this part of the tissue well, and this part of the tissue well. So I want to make sure that I've got about 5 mils, maybe maximum 6 mils of PRP ready to go. However, for a supraspinatus or infraspinatus tear, 3 milliliters is a common amount I use, and the rest just gets discarded. But I want to make sure I've got enough just in case. What am I going to do? So I'll normally telephone the patient. I'll have a phone call set up with them maybe 5-7 days later, just to do a little bit of a cuddle and say, hey, I know this is going to be a bit sore. I'll check in with you in a week and just see how the first week went. I want to give them either Tramacet or Tylenol 3 for the first night especially. Most people will have significant increase in pain when they go home and they go to bed that night. Their shoulder will be an extra heartbeat. It'll just be thumping away at them. And I think it's really bad patient care if you don't give the patient some analgesic, because if 1 out of 20 patients winds up attending the emergency room or urgent care because they're really afraid something bad's going on, that's a huge disservice to the patient. It's a huge disservice to the emergency room, the urgent care community. And so I found that not every one of my patients takes these. Probably only about a quarter of my patients actually use the Tramacet or Tylenol 3. But I give it to every single patient. And I hope that by doing that, I will 100% eliminate the fearful, painful patient that attends the emergency room or urgent care later that night. So that's my personal way of doing it. Well, how about immobilization? Well, I'll only immobilize them if I'm worried about a high degree of pain, and I'll usually figure that out during the treatment. And so I've got some of those just $20 slings I bought on Amazon. I keep them in the office just for the patients that I think are going to be really bad. I'll say, look, use the sling for comfort over the next 2-3 days. It's best if you don't use the sling, I think. I want to keep this moving. However, if you're struggling and you need something to help out, absolutely. Doc, when can I go back to sports? I'll say, that's a great question. What did you have in mind? Why are you asking that question? And they'll either say, I have nothing planned. I just felt like asking the question and want to know when I can get back to normal. I say, look, if you've got nothing planned, that sounds perfect. Give it 2-3 days, nice and easy, and then figure it out over the next 7 days. Remember, I'll be calling you in 7 days and we can chat about it more then. The next patient may say, well, I've got a pickleball tournament tomorrow. Is that going to be okay? And I go, no, I think you're going to be pretty sore and we really want this PRP to soak in. And then I pull out the following study. I've seen studies on rabbits. Poor little, I don't know who's doing. Apologies if you were when you did a master's or a PhD, if you had to do, or an undergrad, if you had to do studies on rabbits, but rabbits or mice. I saw a study in rabbit Achilles tendons. And what they found was they injected, it was a healthy rabbit Achilles tendon. And one of the rabbit Achilles tendons, they injected saline. One of the other rabbit Achilles tendon, they injected PRP. At day 2 or day 3, they would sacrifice the poor little rabbit, and then they'll measure the tensile strength until failure of the tendon. So essentially, put it over here and then put like a newtometer or whatever those force meters are, or strength meters, and then continually adding weight to this end of the pulley until the Achilles tendon ruptures. And what they found was that the Achilles tendons that had PRP injected into them failed with less weight than the Achilles tendons that had saline injected. So what does that mean? That means in the first 3, probably 5, maybe even 7 days, PRP tissue that you've injected with PRP is more likely to fail if it's put under a significant load than if you'd never done anything at all. So that's part of the reason, that's part of the safety reason we say, look, I really don't want you going back to lifting weights or swinging a golf club or thrashing a pickleball, probably for at least a week. Definitely not until we talk in a week. So take it easy. You can do activities of daily living, not a problem at all. When are we going to return to therapy? Once you see the physiotherapist, probably in about a week, but don't forget, we're going to have a phone call in a week anyway. So why don't you book that appointment with the physio? But I'll talk to you in a week before you see the physio anyway. Well, how about when can I really return to sport? I say, look, this is a team sport. I think we should probably get your physiotherapist's opinion based on how you're moving, because I'm not going to see you in a week. We'll talk on the phone, but the physiotherapist is going to have a really valuable opinion about how the shoulders move in. Well, are we going to do another one? I'll say absolutely. We definitely need to do another one. There's a very, very few circumstances where PRP is a one and done. Why? Because we know it doesn't magically heal up the tendon. There are some situations where I've had people say the PRP, man, one treatment and I was fantastic. Absolutely, I'll take that. But for rotator cuff tendons, most of the people I treat with rotator cuff tendon tears are between 40 and 70. And the ones that do well are the ones usually that get 30 to 50% improvement in their symptoms with one treatment. And then they come back maybe a month or 2 later and we repeat the treatment, but they don't get an additional 30 to 50. Maybe they get their 10 or 20% improvement. As the year goes on, then they go back to, think about one patient I've got who's a stand-up paddleboarder and a kayaker and a weightlifter. As the year goes on, her symptoms reduce again. Her symptoms return again. So this one specific patient I'm talking about, who's 65 years old, who's a stand-up paddleboarder, she travels all around the Western Hemisphere and even into Europe doing paddleboarding races for fun. We've done PRP 3 or 4 times and she's done well. But by the time we did that 4th one, I'm filling out the referral form to go chat with the surgeon. Now she'll go chat with the surgeon and she may not want to do the rehab. She may not want to have the downtime associated with surgery. So she's probably going to circle back to me for more PRP over the years, but I definitely want to give her the opportunity to chat with the surgeon to decide if surgery is something she wants to pursue or not. So now how about PRP after surgery? One of the colleagues that I work with in my Calgary office is an orthopedic surgeon, and he's actually published papers on PRP as an adjuvant to rotator cuff repair. So keep in mind, this is a surgeon who's actually going in there and doing rotator cuff repair. and then doing PRP at the time of surgery. Now, what he found in 2 or 3 papers he did about a decade ago was that adding PRP to rotator cuff repair did not significantly improve short-term or long-term outcomes with the rotator cuff repair. And long-term here was, I think, about a year and a half in most of his studies. So it's not truly long-term, but it's long enough term. So the outcome of that was he no longer routinely adds PRP to his surgical patients at the time of surgery. Are very clear. That is not to say that you can't do PRP after rotator cuff surgery. I'm not saying that at all. I'm just saying it doesn't make a ton of sense probably in the days at the time of surgery, or the days after surgery, or the weeks after surgery. I would, if I see somebody with a rotator cuff surgery and they're having ongoing issues, I'm probably not even going to do PRP until month 3, month 4, when they're really starting to push it in the gym, if they're having ongoing pain. So hope that was helpful for PRP for rotator cuff. So what's it look like? What's an example of a normal rotator cuff tear? Or sorry, forgive me, a normal rotator cuff, or a really, really messy rotator cuff? Well, here's a really, really messy rotator cuff with completely disorganized architecture here. And in this case, as my needle was here and I started to push the fluid, almost all of it bounced off and came around the corner into the subdeltoid bursa around the corner way over here. So this is an example of why I always want to have 5 mils, because in this case, the first couple of mils just shot out and wound up in the bursa way around the corner. So glenohumeral joint. So what am I going to do for glenohumeral joint? Now, first off, almost everybody I see for glenohumeral joint injections almost always has premature arthritis that is more advanced than we would expect. It's not like the knee. Knee, you can just have a tiny little rotator cuff tear, but almost everybody I see for PRP in the shoulder has arthritis, and it's a tough one. The other ones that you'll do glenohumeral joint PRP for are going to be people with symptomatic, MRI-proven tears of the glenoid labrum. There's not a lot of great evidence out there for PRP for glenoid labrum injuries. However, what I would say is, because surgery for glenoid labrum tears is so intrusive with such an incredibly long recovery, I think it makes a ton of sense to offer this to patients. Now, in medicine, we get familiar with this concept of number needed to treat. What's the number needed to treat with Prozac for major depressive disorder to get significant symptom improvement? Well, I don't know. I'm going to pull a number out. I'm going to say, let's say it's 7 people. Let's say you got to treat 7 people with major depressive disorder with Prozac for 3 months before they get significant symptom relief. I'll take that. Why? Because major depressive disorder is a huge problem and it's really hard to treat. I want to make sure we give ourselves the same leeway with labrum tears in the shoulder. I think it's a huge disservice to the patient and to our colleagues if we say, oh, I did 1 or 2, glenohumeral joint PRP for labrum tears, and it didn't work very well, so I stopped doing it. So I'm tempted to do this, but I've got to stop myself and say, no, what's the number needed to treat? And I think the number needed to treat to get a significant improvement in shoulder pain, if you've got a symptomatic labrum tear with PRP and you're treating with PRP, I think the number is around 5 to 10. Meaning, now I've got some other colleagues out there who say, oh gosh, no, I get every single one of my patients better. And I'm like, I need to learn from you, because I don't know what you're doing or how you're selecting patients, but that sounds too good to be true in my book. So what I do is I say, look, I'm just going to have in my mind that 4 out of 5 are not going to do well, and 1 out of 5 is going to do great. And that's my win. And that patient's super happy, and that patient's telling all their colleagues about it. And that patient does not need to go on to have more cortisone, a ton of physiotherapy, and surgery that's then going to lead to more cortisone and more physiotherapy. So I think if we take the pressure off ourselves and just say, look, not everybody's going to respond, but darn it, I'm just going to keep treating people until I get some wins. I think that's the best way to do it. as long as it's reasonable. Like it's, like I say, like severe, horrible glenohumeral joint arthritis, macerated labrum, and that's probably not right for PRP. So what do we do for this? Well, I simply go posterior approach. So this is the glenoid. This is the humerus. This is a patient lying on their side. So I'm going to use a curved probe. Sometimes I use a linear probe, but often a curved. And my needle comes straight down and it touches the articular cartilage of the humerus and fills up fluid into the glenohumeral joint capsule. So that's it. It's literally just one single shot. Now, there are some docs out there who say, oh, no, you really want to get your needle into the labrum tear. I'll be like, absolutely. But that sounds a bit more like an advanced technique. And my company, the docs that I work with, we take docs that aren't doing a ton of injections or ultrasound guided injections, and we get them rolling. I don't want you to be unnecessarily distracted or seduced by docs that are saying, oh, no, you got to do this really complex procedure, otherwise it doesn't have a chance. I think you've just got to get started, and you're going to have some people that do well and other people that don't do well. Okay, if they don't do well, maybe we can start doing some more advanced techniques like trying to find the labrum tear, put your needle right into labrum tear and inject PRP. But I think it's totally fine. Just get it in the joint, get them moving, get them doing physio, and see how they do. Common extensor tendon. This is probably the, I would say knee arthritis, rotator cuff tear, and tennis elbow are the three biggest things I treat with PRP. So what do we do with this? Well, once again, not in the first 6 weeks, not if they have a 7 out of 10 pain, not if the tear, a suboptimal candidate is if they've got a big tear in the tendon. So I would call a big tear in a common extensor more than 25% of the tear. I will, once again, I will try to not use anesthetic, but if I'm going to use anesthetic, there's my recipe. I'm going to make sure I've got 3 milliliters of leukocyte poor. I will usually do leukocyte poor. I think it's totally fine if you want to do leukocyte rich or the red PRP. I want to make sure I've got 3 mils to inject, but 1.5 seems to be a common amount. A follow-up patient-reported outcome measure would be the quick dash it's a nice, easy one. It's a disabilities of the arm, shoulder, and hand. I want the patients to do it sort of every month for 6 months. Why? Because, so I've got two quick little anecdotes about common extensor tendon PRP. I've got a 6'8", 320-pound police officer, used to play professional rugby, played professional rugby in 3 different countries. What this means is this guy has been through the wars. He has had people do awful things to him on a rugby pitch, having cleats scraped down his face and people arm bar him and people punch him. And, he's had all these things happen. So I did PRP for his tennis elbow. He came back to me 2 weeks later and said, Frank, that was the single most painful experience of my life. And I said, you have got to be kidding me. You must have had awful injuries. He said, that topped it. So that's an example of how I wouldn't have predicted that. So what did I do? I wanted to make sure this is one of those things I learned from. Now I give everybody Tramoset and codeine because I wouldn't have predicted this guy's pain was that bad. So I said, okay, so most painful experience of your life. Got it. How's it feeling? He said, my elbow feels amazing. I said, seriously? He said, I woke up the next morning and my pain was completely gone. It's never come back. That was at the 2-week mark. Now, I've continued to see this gentleman for other things, and as the years have gone on, he said pain never came back. Single most painful experience of his life, woke up the next morning, pain was gone. So that's a little anecdote I keep in the back of my head. Don't usually see that. The next anecdote was another gentleman in his 60s with tennis elbow he had for a couple of years. And I injected him with PRP, saw him back in the clinic, a month later, just at the checkout desk, said, hey, how's your elbow doing? He said, yeah, no change. Saw him back at the front desk again for something else, maybe about 6 months later. I said, hey, how's your elbow doing? He said, feels amazing. I said, at the 1 month mark, you had no improvement. And now at the 6 month mark, he's doing great. He said, yeah, it was about month 4 or 5, probably. I just noticed the elbow wasn't hurting at all. I said, really? It was really subtle? He said, yeah, like I just didn't think it was getting better. And then one day I realized it was. So those are two simple examples. And I tell patients about those. I say, look, this could be incredibly painful and you'll wake up and the pain's gone, or it really might not be that bad and you don't even notice any improvement for months and months and months. And I don't know which one it's going to be. So let's prep for both. Here's some painkillers for tonight. Otherwise, I'm going to see you back in a month or two and we'll decide if we want to do this again. But otherwise, we just got to give it time. It can take a long time. So what's it look like when you do common extensor tendon PRP? Well, here's a normal common extensor tendon. So there's the radial head over here on the left. Here's the humerus here. What do we see here? Well, we see tissue discontinuity. So I also got a diagnostic course. I've got a free online diagnostic course to get you into our algorithm to help you understand how to analyze and interpret and describe the picture in front of you. Just like when you learn to look at chest x-rays, you got to learn a system. Well, we've got a system for the diagnostic course as well. So it's on our sportsmedus.com. You click on the online courses, you look for the free courses, and you can work through that if you're interested. What do we see? Well, we see that the fibers on the top of the screen, sort of towards the skin, they look like they're intact. They look darker, so we would call this hypoechoic. When you get hypoechoic tissue in a tendon, we should call that tendinosis. Now, when you get black tissue here, or anechoic tissue, we're like, oh, anechoic, it's probably fluid. Why would there be fluid in the middle of a tendon? That's joint fluid that's left the joint and settled in here. This anechoic fluid here is evidence that the tissue is no longer connected. So this anechoic fluid here is evidence that there is a tear. Now, in this specific case, it's the tear in the ligament, because what connects bone to bone is ligament. So in this screen here, up to about this height here is ligament, and then above that is tendon. So in this case, this person has tennis elbow from a radial collateral ligament tear down here, and tendinosis in the overlying or adjacent common extensor tendon. So once again, if you have your 3 mils of PRP and you put your needle here and you push, it's immediately going to flow into the joint, and you're not going to have any PRP left over for the tendon. So you got to make sure you've got more PRP than you think you might need when you go to treat these things. So let's have a peek at what it looks like. So this is an example where I did the red PRP. So you can see that's not yellow at all. So there's a lot of red blood cells in there, but there's also some leukocytes. Again, they're white, but they get sort of magnetically stuck to the red blood cells. So that's why it looks red. But there's also a lot of platelets in that. Now, again, the beauty of the tropocell system is you get a pure PRP that is yellow with no red cell sort of contamination. And if you did want to add in some red cells, super duper easy. All you got to do is with the tropocell system is just pass your needle past the gel and then pull out some of the red stuff that's sequestered down below. But again, there's a lot of docs who do PRP for a living that are moving away from doing the red PRP. So yeah, so you can see he's tolerating this one pretty well. As far as I remember, I didn't use any anesthetic with this one. I could be wrong. I've done a bunch of these. I've got my temporary tattoo there from a trip to Pensacola on the beach I had last year. That's not my bad, my sort of my biker, rose tattoo. It's a silly little temporary tattoo. CMC joint, first CMC joint. I see a ton of people with first CMC joint arthritis. Cortisone is always my go-to. Surgery is the second thing. I've done PRP only a handful of times. Patients tell me it was a lot more painful than cortisone, but they usually say it lasted longer than the cortisone. So this is where I just say, look, here's the options. We can do cortisone. I can send you for surgical consult. Totally up to you. I can't promise you excellent results at all, because most of the results I've had with PRP haven't been that awesome. But hey, once again, we get back to the number needed to treat, just like the Prozac and major depression. I think probably the number needed to treat with PRP for pain with moderate to severe CMC joint arthritis is probably sort of like 7 to 10. meaning a bunch of the patients are going to be dissatisfied and say, no, I just want to keep doing cortisone. But you're going to get some of those patients who say, man, this was so much better than cortisone, and I know it's not going to be degrading the cartilage or degrading the ligaments or degrading the joint. I'm going to keep doing this PRP until it's time to have surgery. So what's it look like? So this is a gentleman. This is one of the gentlemen who he's a younger man. He's only 40, and he's got severe first CMC joint arthritis. Is sort of a hereditary thing. What we're looking at here is bone 1, bone 2. So in this case, on the right-hand side is actually the metacarpal. Over here is the carpal. In this case, it's the trapezium because it's the first CMC joint. And in this case, I only put in 0.4, 0.5 mils of PRP, just because I know that when this gentleman's joint gets sort of stretched with the lidocaine or cortisone or whatever, or PRP, whew, you see his little veins pop out on his forehead just because that joint is so sensitive. So this, I would say, is a suboptimal candidate for PRP, but we still went with it because he'd had cortisone 25, like literally no joke, at 40 years of age, he's already had cortisone 25 times in that joint because it's been grumbling since he was about 32. So of course we're going to try a PRP once and see how he does. And he said it lasted longer than the cortisone, but not long enough that he wanted to continue it because it was quite painful. Hip joint, once again, labrum tears, osteoarthritis. I think the number needed to treat with PRP to get a good result from some hip joint arthritis. If you take people in their 30s, 40s, or 50s with mild degenerative changes or small labrum tear, I think the number is probably 2, meaning you get, it's about 50-50. A lot of patients say, hey, 50-50, I'm not cool about that. I'm like, okay, perfect. Cortisone will be 100%. And it's going to make your cartilage worse, and it's going to make your ligaments worse, and it's going to mess up your blood sugar for a couple of days. And they go, okay, let me try the PRP. So it's totally up to you, your style about how you pitch this to people, but please don't overpromise and underdeliver. I usually do the opposite. I underpromise with the hopes of over-delivering. And the more hip PRP I do, the more the active patients who like cycling, the ones who like running, man, it just doesn't work that great for them. But the ones who cycle or cross-country ski or they're kayakers or whatever, I think PRP is a really good chance of helping them. But once again, I don't think it's much in my hands, in my clinic, in my experience, I don't think it's much better than 50-50. But your patients deserve the opportunity to give it a try, personally, is what I think. But you start getting people with severe arthritis, bone-on-bone arthritis, and they go, geez, I just want to do PRP. I tend to steer them away from it unless they're super duper keen on it. Because I think the number needed to treat, if you've got severe arthritis, number needed to treat with PRP to get a good outcome, it's probably like 20, maybe 30, maybe 40. So it's certainly not something I push. So what do? Well, you literally just drop your needle down to the bone. So here's an example of a femoral neck going up to a femoral head. This is actually a thickened capsule. This was a gentleman I treated with PRP several times because he'd had sort of a bit of a labrum tear symptoms and he felt like the joint was wobbling around. We treated him with PRP a couple of times and he actually got thicker, stronger capsule. I couldn't believe it. I actually measured it. It was unbelievable. That was the only one I've actually ever seen where the ligaments actually got a ton thicker, but it proves the concept that the PRP can thicken up tissue. And here's a gentleman with, here's the femoral head. Here's a bit of fluid in the joint. This is the articular cartilage. You drop your needle down here to the neck and it flows up and around the corner. What's it look like in practice? So this is that gentleman. So I'm using the gentleman on the left with the capsule that actually got thicker. Here's my needle right up against the bone. You go down to bone, you stay on bone. None of this go down to bone, pull back a bit and inject that we get taught with landmark guided injections. No, you got to go down to bone and stay on bone. Why? Because if not, if you go down to bone and then pull back a bit, you're going to be injecting into the joint capsule ligaments, or you're going to be injecting outside the joint capsule ligaments. So with these injections, you go down to bone and stay on bone. I think that glute, so I never put PRP into the glute, into the greater trochanter bursa. because I don't think it's the best way to do it. You always put it into the tendons. So glute min tendon, glute med tendon, I think PRP is an excellent treatment option. I think the number needed to treat with to get good response with PRP for glute med, glute min tendon small tears, I think the number is about 1.5. So essentially, you treat 3 people and 2 of them will come back and say it helped. But these people are sore. You got to handhold, you got to get them doing physio, you got to get some painkillers, because this is irritable tissue. But I genuinely think you treat 3 people, 2 of them are going to get a lot better, but it's going to be slow. It is going to be slow and painful. But that's going to be the same whether you treat them with Prolo or exercise, or like, there's no surgery for this. So I think PRP is a fantastic option. So this was a gentleman who actually I was treating him with PRP for a quadriceps tendon tear, and he said, you know, I felt like a snap in my butt. I'm like, oh no, what have you done? So I checked him, and he actually had avulsed the glute med tendon off the bone. So what did we do? Well, we did some PRP. He was there for the PRP for the quad tendon. I said, look, we'll get some in the remnant tissue that's still attached to the bone and the adjacent tissue. Once again, he did something like this. Sorry, he did something like that. I got to be careful which fingers I'm putting up here. He did something like that. And so I made sure to touch all this tissue and touch this tissue that's still attached. Haven't seen him back in a while. So I think I saw him once after this, and he said the PRP was helpful, but I can't remember if we did, and I don't think we did anymore. SI joint, I'll do SI joint PRP after I do cortisone. Usually I'll do Prolo next, and then I'll do PRP next. It's a tight joint. People don't tolerate it that great, and I think you can get some really good response with simply some dextrose. So that's usually my go-to. What's next? Knee joint. Well, I'll usually I've injected up to 50 milliliters into a knee joint of PRP. It was a very unusual situation. And a guy who didn't want a knee replacement, he had a huge Baker cyst that kept recurring, and so we drained 50 mils off his knee and put in 50 mils of PRP. It didn't help, but that was something that we did. That was a one-off. The maximum I'll usually do is 15 milliliters. The beauty with the Tropicell system is you can, in this case, I would usually do a 22, I do a 44 or even a 66 mil draw, because I want a lot of platelets going into it. And we know that knee joints can hold a lot of fluid. And so I do not think you need to put in super duper concentrated 3 or 5 mils. I think you can get away with 8, 10, 12, even, you know, up to 15 mils of PRP into a knee joint. Again, it sounds a bit aggressive, and maybe you don't do it with the first one or the first 10 or the first 20. But once you get about 50 or 100 knees under your belts, you really want to get a lot of platelets in there. So that's knee joint. So what do we do? Well, this is an example of a normal knee joint. This is the patella on the left, the femur, patella on the right, femur on the left, and there's the knee joint fluid. So this is completely normal. This is an example of an effusion. So what do I do when I have an effusion? When I have an effusion in the knee joint, I will drain almost every drop, and then I'll put the PRP back in. Why? Same as the anesthetic in the tissue. You don't want to do the anesthetic in the tissue prior to the PRP, because you're just watering down your product. So if you put PRP into the synovial fluid without draining it, you're really watering down the product that you have spent all this time and effort trying to concentrate. Here's an example of where I did PRP into a knee joint. This was an atypical approach, but I had a camera crew in that day, so I just wanted to capture this one. So I went, here is the medial condyle of the femur, here's the patella, and I'm coming in plane. There's my needle, and it's dropping down into this fluid of the knee joint. And so once again, not a typical approach, but it was just an additional video that I wanted to capture when I had the camera crew in there. So I'm just an invitation. I am on the board of directors of a group called the American Academy of Orthopedic Medicine. We teach stem cells, Prolo, PRP, and a whole bunch, and nutrition and lifestyle change for optimizing orthopedic conditions. Last year at our conference, Joe Albano gave a good talk about how he treats meniscus tears. So we've got our national conference coming up in Portland next week. A year from now, we're going to be back in Pensacola. So keep us on our radar if you're interested in learning a bit more from some of the leaders in the field. So what else do we have? Oh, here's an example of that patellar tendon in this 16, 17-year-old kid. Normal appearing patellar tendon there, but then we move to the side and you can see the tendon has darker areas consistent with tears. There's areas where the tissue just looks a bit yucky. And I can't believe how well he tolerated this. He tolerated this like a champ. I used only the tiniest amount of anesthetic on one of the knees and none on the other, and he was amazing. Haven't seen him. I did it twice. Haven't seen him back in follow-up to see how he did. I think with patellar tendon, with nasty, gnarly patellar tendons like this, with all this dark area of tearing and tendinosis, I think your number is probably like 3. I think you treat 3 people and you get 1 really good response. But this is a really tricky condition, right? So I think treating 3 and getting 1 good response is a massive win. Like I don't think that's a failure at all. Okay. Ankle joint, we've got a podiatrist from the Mayo Clinic who teaches our podiatry courses with us. And I said, man, I just don't do PRP very much in ankles. And she said, that's funny. I do PRP in ankles all the time. Well, of course it is, because that's her bread and butter. The ankle joint for her is like the knee for me. I treat people with knee arthritis all the time. So I think if you have a maximum amount of 6 mils of PRP for the ankle, I think the ankle can hold like easily 10 mils. And that's overcooking it a bit. But I think if you have 6 mils ready to go, 3 or 4 mils is a common amount. Follow up with the FOAS. This is the Fellow of Orthopedic Ankle Surgeons. I think that's what that is. I've forgotten what that acronym was. But once again, use your patient-reported outcome measures to capture the small improvements in patient symptoms. So what's an ankle joint PRP look like? Well, this one actually just, I don't think I have a good recording of an ankle PRP, but with ultrasound, what you're going to do is you're going to find the tibialis anterior tendon. You're going to see the distal tibia. You're going to see the talus, and all this other stuff here is synovium. This is the articular cartilage of the talus, and all you're going to do is drop your needle into sort of the squishy spot, just anterior and distal to the medial malleolus. And you're just going to drop that needle in there. And once again, this is a cortisone injection, but the injection for PRP is the same. So we'll just hit play on that. And so what I've done in this case is I've now turned my probe to the side, and my needle is here touching the side. Oh, my needle's there touching the side of the talus. And we are safely away from the dorsalis pedis artery, and we're safely away from the tendons. So once again, that angle drops the needle onto the side of the talus. There's also other injections videos in this PRP course where we do the ATFL. In this patient, I did the ATFL, the AITFL, the deltoid, the tibialis posterior, the tarsal tunnel nerve, so tibial nerve, along with the retinaculum in the tarsal tunnel. So that essentially is my guided tour through the top 10 injections I do with PRP and ultrasound. Here's an example of an injection for plantar fascia, and you can see this. Once again, this one of the military guys, right? This was a hyaluronic acid injection, and if he didn't do well with the hyaluronic acid, we were going to do the PRP. But he did great with the hyaluronic acid. I think if you do PRP for plantar fascia, if you do 4 people, I think one's going to have an amazing outcome, and the other 3 are going to be not so great. That's my personal opinion. I appreciate your time, appreciate your attention. And again, if you want to add PRP to your practice, please head to SportsMed US, go to online and look for the free courses, because we've got a free PRP course there to get you rolling, to get some of the wheels turning, to break out of your inertia, so you can start to add this to your practice. And if Craig and his team can contact you with some information about the Tropicell system, you can evaluate that and see if that's right for you.
Yeah, great. Hey, thanks, Dr. Johnson. Appreciate that. Anybody have any questions? Just throw it in the chat. Once again, Transcend Biologics is happy to host and support Dr. Johnson and his ultrasound courses that we have. We got a lot of products that would benefit you in your clinic, and we would love to partner up with you as well. So I'll open it up for questions and see if we have any.
Oh, thank you so much. Oh, Mike G. Mike, glad you were able to come. Charlotte, thanks so much. Again, I think the way to get started, so I'll just do a little commentary here. I think the way to get started with PRP is to simply get something, get a PRP preparation system in your office that your staff are happy with, that there's no fiddling around, and I think that's where the Tropicell system it really shines. I think you also need to have some reps in your area that are willing to come in and help you troubleshoot if there's any issues. I think you need some online learning, and the Tropicell system has an online university. Transcend Biologics has put together a really good sort of online course to help you and your staff learn how to use the product and troubleshoot. And I don't think many other vendors have done actually a good online course. So Eddie, for whatever that's worth, if you're just looking at bringing this into your practice, I think it's a nice, simple, predictable system with reps all around the country that are there to help support you, and online learning to help you work through any hiccups should they occur. Excellent. Well, thank you so much. It looks like people might be turning on the basketball game and watching basketball off on their other screen. So thanks so much.
Go Razorbacks. Go Razorbacks. Go Razorbacks. Go Razorbacks. Anyway, hey, thank you, Dr. Johnson. Appreciate you.
Thanks so much. Have a great night, everybody.